Hi guys, I'm Dr. Ramakrishna Chaitanya, consultant anesthesiologist and a critical care physician. So INI-CET November 2022, it was filled with lot of surprises. The exam pattern, it has divided into session 1 and session 2, and surprisingly the results also came out very quickly. So you might have already attempted this examination and some people might not have attempted also, but fine. Some are happy with the results, some are gaining some experience. At the end of the day, it's finally what we can understand is writing examination and getting our dream branch is our final goal, right? So in this session, this is basically a recall session. The questions have been recollected from the students from various sources, and I am trying to analyze these questions for you so that you can prepare, or what are the we can understand what are the target areas that they are focusing, so that we can prepare for the next examination, that is our NEET PG, right? So let us quickly review what are the questions that I have asked. As usually, anesthesia, it's not like they have asked every year. They don't direct. They put a straightforward question. So they have asked in the same way that with lot of mixing with other subjects. So you might have heard these questions, or you might have seen these questions somewhere, or it has been discussed in other parts. Purely anesthesia questions are one or two only. So some critical care questions, some mixed with pediatrics, some mixed with pharmacology, etc. So let us jump and see the discussion of these questions, what have been asked, and what are the areas we need to concentrate so that we can improvise ourselves in the NEET PG examination, right? So shall we start session one? Right. So first question, what it has been asked. A 60 kg ARDS patient on ventilator with 5 centimeters of PEEP, 360 ml of tidal volume, and an IE ratio of 1:2, or pH of 7.38, pH of 7.38, and a PaO2 of 50 millimeters of mercury, PaCO2 of 35 millimeters of mercury, and with an FiO2 of 90 percentage, 0.9. What is the next best step? Okay, so the question, if you look at the question, if you have, this is a very common question which we have anticipated, because after the COVID, every year in the INI-CET, they have been started asking some question related to critical care. So in our modules of routine videos, we have discussed about this anesthesia. Along with anesthesia, we discussed about the critical care, the care of the patients when a patient is on ventilator. And in the ventilator, because there are so many equations on ventilator, to pinpoint and say that this is the case and how to manage this case, that will be difficult. So I have given an outline of how to take care of a patient on ventilator, and I have told you various modules, what are the normal values of the modules, and how we are going to take care of a patient on ARDS, like something like COVID like scenario. I have given, I said you non-invasive ventilation is better than invasive ventilation, something like that we discussed. Now what he has given is, he has given a clear picture of an ARDS. There is no ambiguity here. So this is a ARDS picture of a patient on ventilator. If you see the settings of the ventilator, I'll put it in a simpler form rather than in a theoretical form. I'll put it in a simpler form. See here, FiO2 is 90 percentage, that is 0.9. Okay, and tidal volume, he has kept it around 360 ml. That's also fine. And the respiratory rate, he has not mentioned the respiratory rate. Fine. He has mentioned the IE ratio is 1:2, right? And the PA and yeah, that's it. See the tidal volume and a PEEP value of 5 centimeters. Right. Now, these are the settings on the ventilator. We don't know the respiratory rate, but what we can assume is the patient weight is 60 kgs. That means he is going on with that low tidal volume, that is 4 to 6 ml per kg, or some book says 4 to 8 ml per kg. Right. So if you put it also, the tidal volume is appropriate for this patient, and the FiO2 is on higher side. If you look at it, maximum you can go is 100, that is 1. He has kept up to 0.9 percentage. Okay, 90 percentage he has kept. Now let us look at the patient general condition. So the patient, if you look at the ABG of the patient is having pH of 7.38. It's okay, acceptable, slightly on alkalotic side, fine. The PaO2 is 50 millimeters of mercury. Now see here, the point here is, maybe I am wrong at the numbers, what we have recollected from the students, but please try to understand how I am approaching a patient on ventilator. That's the key point here, because every year, as I said you, they are asking a question which is related to, like in the beginning of the COVID session, they asked about high flow nasal cannula. In between, he has shown the image also. Now he has put a classic picture of ARDS and he's asking what is the next best step. Now see, please try to understand how we are proceeding in this case. So see here, he has not given PaO2, he has given 50 mm of mercury, that is, it is on lower side. What is the normal PaO2 for a patient? If I take your ABG sample, what will be the PaO2? The PaO2 will be somewhere between 80 to 100 for a normal patient. Right, if you are mechanically ventilated with increased FiO2 values, definitely your PaO2s will be on higher side. But here in this patient, ARDS patient, the classically what it is showing is the PaO2 is on lower side, and PaCO2, see here, PaCO2 is 35 millimeters of mercury. That means he has used low tidal volume, and he has not mentioned anywhere about the respiratory rate. But by looking at the PaCO2, you can say that he is providing good amount of ventilation. Right, the PaO2 tells the oxygenation, PaCO2 tells us about the ventilatory strategy of the patient. Now see here very closely, the patient, even though he is having high FiO2 values, he is getting good amount of FiO2 values, and he is ventilated good, and he is ventilated with low tidal volumes, and also he is ventilated and his PaCO2 levels are also normal. That means adequate amount of respiratory rate has been set. Now the PEEP is 5 centimeters. Now, if you look at the picture, what do you want to improve? It's very simple and straightforward. You want to improve the PaO2 of the patient, because the target PaO2, if you have recollected your medicine in ARDS, there is something called as ARDS net protocol, right? So the target PaO2 is, we want to keep it more than 55 millimeters, 55 to 60 millimeters of mercury. Because in ARDS patient, the lungs have become very stiff. The compliance of the lungs have been completely damaged, right? So there is difficulty in oxygenating the patient lungs. Now the target is to keep more than 55 or 60 millimeters of mercury, but here the PaO2 is already, the PaO2 is on lower side. Now, what is the next best step? Now, see here, our target is to improve the oxygenation of the patient so that his organs will not suffer from the hypoxic damage. Now, if you look at the values, see here, the first option he said, increase the IE ratio to 1:3. I said it very clearly in the ventilatory strategy of the patient. In a patient with ARDS, we generally don't use a conventional respiratory IE ratio. Normally, we use 1:2 ratio, but in ARDS patient, because our priority is oxygenation, we can sometimes use inverse ratio ventilation also. There is a mode I discussed that is called as inverse ratio ventilation, where I give more time for the inspiration. Right? Suppose if he had mentioned 3:1, maybe that might be the correct one. But here he said he wants to give more time for the expiration. If I am giving more time for the expiration, that means I am allowing carbon dioxide to wash out from my body. But already here the carbon dioxide levels are normal. Why do I want to wash out the carbon dioxide? So this is not a very good answer, or this is not a next best step to improve the oxygenation. By decreasing the IE ratio or increasing the IE ratio to 1:3, you might not improve the oxygenation of the patient. Right? Now, increasing tidal volume. So it might be looking a good option. But as I said you, for a 60 kg person, if you are ventilating, it's a case of ARDS, the goal is to maintain low tidal volume and increase respiratory rate. If I use high tidal volumes, definitely there might be chances of barotrauma for this patient. So again, increasing tidal volume might not be a good option for me. Right? Increasing in the PEEP. Now see, this is the very classical point you need to understand here. Why are we, let us talk about increase in the PEEP later. Let us see the next option. Increase in FiO2. Already the FiO2 is 90%. What he has mentioned is FiO2 is 90% in the question. Now see here, what is the point in increasing FiO2? By providing 100%, I can't ventilate a patient. My goal is to maintain a saturation. I told you in the class also in ARDS patient, the saturation to maintain between 92 to 96. I'm happy with these numbers. I don't want 100% saturation for this patient. I want any value in a patient depending on the general condition. I want any value above 90% for the saturation. Preferably, I want to keep it around 92 to 96% of SpO2. That's my goal. right? With that SpO2 values, I might increase the PO2. Now, by increasing FiO2 to from 90 to 100% and providing prolonged ventilation may cause oxygen toxicity for me. So this is not a good option for me. So what is the best option? What I can do for this patient is to increase the PEEP. Conventionally, what we do in an ARDS patient is we apply a high PEEP strategy. I told you in the class of ventilation, please, if you have not listened to that video, have a look at that video. I told it very clearly. We use low tidal volumes, increased respiratory rate, and we apply high PEEP. How much amount of high PEEP? Now, there is one thing which I have not covered. This slide I have not shown you in this ARDS net protocol what we are following, because already they might have taught you in your medicine in the medicine part how to manage the ARDS. So see here, in any ARDS patient, this is our target. So we keep a FiO2 and PEEP ratio. See here, if a patient is getting 30% of oxygen, what is the amount of PEEP we are trying to keep the patient? We are trying to keep the PEEP about 5. So here our target, if you want to get a good saturation, our target saturation values for the patient, then definitely you have to follow this. So here the patient is getting 40%, your PEEP is 5. It's fine. Okay. If the patient is increasing the FiO2 to 70%, you are increasing the PEEP to 10. Right. In the same way, if you are using 90% of, if you are using 90%, that is 0.9 FiO2, that means your PEEP value should be somewhere between 14, 16, 18 to improve the oxygenation. Now, what is the PEEP value here? What he has mentioned? He has mentioned only 5 centimeters of PEEP. This is the problem why the oxygenation is not improving, because inherently in an ARDS patient, the lungs, the alveoli are trying to collapse. Alveoli are trying to collapse. We are trying to keep the alveoli patent. How can we keep the alveoli patent? Is by applying PEEP. PEEP means positive end expiratory pressure. We all know this, positive end expiratory pressure. It tries to open up the alveoli. Now, how much PEEP we need to keep for a patient? Ideally, for a undergraduate, unless you are working in an ICU, you are taking care of the patients regularly on ARDS, you don't have to remember all these values, but simple logic, if you go by logic also, you can see here, by improving to improve the oxygenation, you need to increase the PEEP. So here the target is to increase the PEEP, and if you want to increase, if you have increased the PEEP, then automatically you will get into your target range, and you can see the patient condition might be improving. So this is a very classical scenario of ARDS. Most of the students, they might get tensed by looking at the ventilator, because many of the students at your level, at undergraduation level, some of you have might gone into an ICU, managed a patient on ventilator, or routinely you are having postings in the ICU and you are seeing the patients on ventilator. Some students might not have been seeing on the ventilator, but simply if you know the basics of the physiology, respiratory physiology, that's what I have been telling you in the routine video classes. If you know, because in a patient on ventilator, I talk to many students, they say, sir, what are these ventilatory numbers, sir? We are confused with this number. No, there is nothing much you can confuse. If you know your physiology well, that's what I am trying to apply for my patient, right? That's the only point that's the only stress we need to make. So by keeping a patient on ventilator, what we are trying to do is we are trying to bring back the patient normal physiology. I told you very clearly, how do we manage the patient? How do we take care of the hemodynamic care? How do we take care of a patient on ventilatory settings? What are the various modes what we can keep a patient on? So all these things we have discussed. Go and watch that module. It's a very small module, around 45 minutes or 50 minutes. I discussed about it. So practically they might give you any situation. One of the scenario is ARDS. The second scenario, till now they have not asked, but the second scenario you need to understand is to remember how to maintain a patient on COPD. Because there are two kinds of diseases. For me, a patient on ventilator, there are two kinds of diseases for me. One is ARDS kind of picture. The second one, if I want to ask you anything new, I might give you a picture of COPD. So now in this examination, they have given a picture of ARDS. They might, or there is a chance, there is a probability that they might ask you about COPD management also in the ventilatory settings. So here you can understand in ARDS picture, the point is, the problem is oxygenation of the lungs, right? Whereas in COPD picture, the problem is with ventilation of the lungs. Here the carbon dioxide will be accumulating, here the oxygen will not be accumulating. That's the difference, right? You all know the basics of respiratory physiology. Again, I am not telling it. So please try to understand the respiratory physiology. That's how the ventilator works. Okay, it's not something like Greek and Latin to us. If you have not listened to that video module, please go and listen to it. It's a very simple module, and by applying simple respiratory physiology, you can understand what to do the next best step. Okay, there is nothing, there is no hard and fast rule. There are something like these guidelines are there, but you need not remember. As far as for your NEET examination is concerned, they will not ask you how much PEEP they definitely want to keep on a patient or something like that. So we apply a simple strategy of high PEEP. Here the patient is getting low PEEP. That's the reason why his oxygenation is not improving. So if you think logically, that's what the INI-CET examination expects from a student. Think logically rather than getting a simple straightforward question. Think logically and you get the answer in front of you. So this is the first question that have been asked with a critical care touch. Shall we move to the next question? Right. What is the second question they have asked? Which of the following nerve is blocked for hernia surgery? Some students, they said it is like for femoral vein cannulation. I don't know exactly. For hernia surgery, below the inguinal ligament. Okay, fine. So what is this, sir? Is this really an anesthesia question? Yes, it's a really an anesthesia question, right? I do this block daily, day in, day out for hernia patients. I do this block very regularly for my patients, right? Now, sir, you have not taught what is hernia, where it is coming, what is this hernia block? We don't know. You need not remember it. I told you in the class of regional anesthesia. Regional anesthesia means anatomy. Anatomy. That is, if you know where the nerve is going, which area it is supplying, that is where they are going to ask. Now, understand that 2 years back or every year in INI-CET, they are showing one area. Like last year, they have asked one nerve, they have marked it on the anterior part of the nose and asked what is the nerve block that you are giving at this region. Okay, some anterior ethmoidal, something like that. They have given the option. If you know your surface anatomy of the nerves, where the nerves are there, if you know it, you can easily answer this question. So I said you that's the biggest advantage of regional anesthesia. Regional anesthesia, it is divided, I told you in the class, it is divided into central neuraxial blockade and peripheral neuraxial blockade. So all these days in INI-CET examination, they are asking about peripheral neuraxial blockade. They are not asking what is the technique. They are asking, they are just linking it with anatomy. They are just putting it with anatomy and they are asking like, what is this now and what is the block? If you know your anatomy, that will be clear forward. Right, you need not listen to all of the things. So hernia surgery is going on. What is the area? What are the nerves you are getting going to be? What are the nerves you are going to encounter during a hernia surgery? If you remember, there are 3 nerves. Okay, ilioinguinal nerve, ilioinguinal nerve, iliohypogastric nerve, iliohypogastric nerve, and genital branch of genital femoral nerve. Genital branch of genitofemoral nerve. Genital branch of genitofemoral nerve. Right now, see here, see this image. This is a classic image which I picked up from the anatomy. Now, see here, this is the hernia surgery. This is the inguinal nerve. Here, can you appreciate the inguinal nerve? Iliohypogastric nerve. There is a femoral branch and a genital branch. Right, so can you see the nerves how they are going? So this is the inguinal ligament. Can you appreciate this? This is the inguinal ligament. So they are asking for some femoral vein cannulation or hernia surgery, we don't know, but they are asking what is the nerve that we are going to block in hernia surgery below the inguinal ligament. So this is your inguinal ligament. So opposite side also you will have the same inguinal ligament. Right, now what is the nerve that is coming down? See here very clearly, there is only one nerve, that is genital branch of genitofemoral nerve or femoral branch. So in your options, he has not given much, he has not put you on much confusion. The straightforward option he has given genitofemoral nerve. That's a straightforward answer. So why not femoral nerve? Femoral nerve, if you remember, what is the area that is supplied by the femoral nerve? Femoral nerve, I told it in the class, how to give the femoral nerve. In the video section of peripheral nerve blockade, I told you how to block a femoral nerve. So just very simple, try to palpate your femoral artery and 1 centimeter lateral to it, there is a femoral nerve. And if you remember your anatomy, the femoral nerve supplies to the anterior part of the thigh. Anterior part of the thigh. Right, this area is supplied anterior part. It's not used for, and it is used generally, we use it for some skin grafting, some total knee replacement surgeries or something like that. It is not used for hernia surgery. So femoral nerve is not a good option. What is the other option? Lateral cutaneous nerve of thigh. If you see the image, lateral cutaneous nerve of thigh, the name itself is saying lateral cutaneous nerve. Here is your lateral cutaneous nerve. It is moving away from it. Right, so lateral cutaneous nerve, there is some disease that is called as myalgia parasitica, where if you have large ascites, there can be chances of numbing of this area, lateral side of this area, right? So this lateral cutaneous nerve was also nowhere related to this hernia surgery, right? So this is also not correct. Obturator nerve. Obturator nerve is the nerve that supplies to the adductor muscles of the hip. Adductor muscles of the hip. That means on the inner side. Can you see here on the inner side of this or on the complete medial side of your thigh, it will be supplied by your obturator nerve. So the clear cut answer, if you know your surface anatomy, the answer is in front of you. That's the beauty of the regional anesthesia. You need not learn anesthesia fully. If you know the surface anatomy, if you know the surface landmark where the nerve is present, then the answer is in front of you. Okay, so this every year in INI-CET, again I'm telling you, they are showing one nerve. Suppose they might ask you, what is the nerve that is present here? What is the nerve that is present at this epicondyle? This is the ulnar nerve. So if you know that there is an ulnar nerve here, and if you put a needle here and give the local anesthetic, that will become the ulnar nerve block. Right, in the same way, wherever there is a nerve, you can block it, provided you know the surface anatomy. This is what the statement I give you at the beginning of the chapter of peripheral nerve blockade. It's not like I am telling you that I have told you, but this is the application part. So please try to understand, rather than concentrating on the videos. For an exam pattern like INI-CET, you really need to know how the question examiners are trying to apply the knowledge, rather than giving a simple straightforward thing. They are asking, so this is the surgery and what is the nerve? So if you know that femoral nerve supplies to the anterior part of the thigh, obturator nerve supplies to the medial part of the thigh, lateral cutaneous, it supplies to this. So what is the left out one? The answer is genital femoral nerve. Okay, so this is a classical question where we are applying, keeping the anesthesia and anatomy together, and we are trying to apply it. So those candidates who are preparing for the INI-CET examination, those who are targeting this examination, make sure that you concentrate on critical care area. The second one is regional anesthesia. Classically, they are asking these questions. Okay, shall we see the third question? Right. The third question is, which of the following is used in the cannulation of newborn? Again, this is not purely an anesthesia question, but most of the times, this is somewhere it is related to pediatrics also. But I'll try to cover here, because we get in a hospital, we get a very frequent call from the pediatric ICU. I told you, one of my biggest, in my routine videos, I told you, I am a pediatric anesthetist by as working. So what I do is, one of my biggest nightmare is if I get a call from the ward to put a cannula in the child. I told you this thing in the video, right? So what are the things that are required? So this is practically, I didn't expected this one. They will ask you what are the things that is required for it, but they have asked this one. That means they are concentrating more on the practical aspects. Okay, I told you about EMLA cream. I told you how to put a cannula when we are using sevoflurane. I showed you a video also where when I am putting a laryngeal mask airway and for a child, etc. Right, now here he has asked very practical point. What are the things I am going to carry? Unfortunately, if you have put a cannula for a child, you will understand what are the things you will carry. I didn't expect this one. They will ask you. It's a very simple, straightforward one. Let us look at the options, because by looking at it, everything we can't tell it in the video session, right? So they have asked it, and we are stressing it from not only looking at the videos. attending your postings, putting a cannula, putting a Foley's catheter, putting a rice tube, all these things are mandatory, not only endotracheal tube. So what are the things you carry when you are putting a IV cannula in a child? So definitely a newborn, he has specifically mentioned. Newborn means obviously I use a smaller gauze needle. We have the gauzes from 14 gauze, 16 gauze, 18 gauze, 20, 22, 24. So preferably, which one I have to choose? We all know that we choose a 24 gauze needle. 24 gauze IV cannula, needle or IV cannula, right? Which is an yellow color one. Right? So you can see here, every year, again, they have been asking question. Till now, they have asked in the beginning days, if you look at the trend, in 2016, 17, something like that, they asked a question on the color of IV cannula. Last year, observe the trend, very simple trend they are following. Last year, in the beginning year, they have asked for the color. Last year, they have asked for the flow rate. In between years, they have asked where it is used. Like, for example, 16 gauze, trauma, massive blood loss, we will use. For 20 gauge, normal IV or blood transfusion, what they will use. We have all been talking about it. Now, this year, they have slightly modified the question and asked, what are the equipment you are carrying? So, for a small child, 24 gauze cannula, neonates, newborn, children, very old, very small children, we use a 24 gauze cannula. Preferably, I will try to use a 24 gauze cannula. If the patient is slightly older, he has clearly mentioned it is a newborn. So preferably, I will try to choose a 24 gauze cannula. That's fine. Then what I will do is, once I put the cannula, practically, most of the times putting a cannula is difficult. Most of the times there will be chances of double puncture. It might look that I might have kept the IV cannula very clearly, but if I flush it with a syringe, sometimes there can be swelling around it. You might have observed it. Especially this is very common, not in adults, but in children, because the veins are very thin and fragile. Right? So a 5 ml syringe with normal saline. Please remember this. I am telling you, practically, I do it in a day-to-day basis. If you have not kept a cannula for the child, remember, don't use distilled water for flushing. Most of the times you might be using it, but if it is extravasated, it is very, very painful for the child. If you notice, if you flush the child, the cannula is extravasated, the child will cry vigorously. Most of the times, if you notice it, giving a needle prick is not painful for the child, but if you are flushing it, that is slightly painful, because the vessels are stretching, and if it is extravasated, that will be very painful for the child. And that too, if you use distilled water. So preferably, we flush the cannula with 5 ml syringe and with normal saline. So this is also required for me to put a IV cannula for the child. Adhesive tape, obviously we know that without a tape, nothing will be there. Because if you put the cannula and relax, what will happen? The child will throw the hand and the cannula will be out of the ward. And again, you need to repeat it. So adhesive tape is also normal. Normal saline is also, it is there. So what is the odd man out in it? Obviously 22 gas cannula. 22 gas cannula, I don't think it will be easy for me to put it in a newborn. Yes, if the question they have asked for a child, maybe 22 gauge cannula for a 3-year child, 4-year child, fine, I can use it. For a newborn, definitely either 24 gauge cannula or a 26 gauge cannula. Preferably, I choose 24 gauge cannula, because 26 gauge cannula also, the flow rate is very, very minimal, and I need to, I have to be very careful while giving the drugs. Okay, so please remember that this is the way they are asking. So it's again, if you have put an IV cannula in a child, or if you have put it in an adult also, you can think logically and you can answer this kind of question. That's the reason why we always stress that not only listening to the videos, do the procedure. Do it for yourself, you will never forget. And this is a very practical application of the keeping a cannula in a child. Right? So please remember, take home point for your entrance examination. Remembering color is mandatory. Remembering flow rates was also mandatory. Now they are asking how they are putting it. We don't know what we can expect in the future also. Okay, so please remember, this is again a repeated question in a different format. That's what is the INI-CET examination, right? So please gear up and for the next coming examination. So this is again, the trend is same. right? So shall we move to the next section? Arrange the following steps done in a sequence for a patient who is unconscious. Again, this is, we have repeated this question many times. There is something we have in this edition 6. I have taken a special module on BLS and ACLS, that is basic life support and advanced cardiac life support. And every year, not only in INI-CET examination, they are asking this question even in NEET PG examination also. So what is the step? I don't remember exactly what are the options they have asked. Some students, they said look for breathing or something like that, but these are the very, most of the students, they accepted this options. So that's the reason why I kept these options. So what do you do in a basic life support? This is what the algorithm we have discussed. So we have given an algorithm. I have not given this algorithm. This I have copied it from ACC-AHA, that is American Heart Association. We have copied it. We discussed in detail what to do. So when a patient is unconscious, what you have to see? First thing is you have to see the scene safety. Obviously, that's not there in the option. What is the second best step? Check for response. This is the first step you need to do. So first step, what you have to do is check for response. Then call for help. If the patient is unconscious, not responding, immediately activate your emergency system. In our country, it is 108. In foreign countries, it is 911. Then wait, check for the pulse. Right, check for the pulse, preferably central pulse. Time should be less than 10 seconds. We have stressed this word, less than 10 seconds, right? Then what you have to do? Then what you have to do is immediately start chest compressions, high quality CPR. When a patient, if you are not feeling the pulse within 10 seconds, 5 to 10 seconds, you have to feel the carotid pulsation or else femoral. Mostly we choose carotid because it is convenient for us to choose the carotid pulsation. If we are not able to feel the pulsation, then immediately we will start the high quality chest compressions, right? So 30:2 is the ratio, 30 compressions followed by 2 breaths. Then the main priority, as we all know, it is not ABC, it has been changed long back, that is compressions followed by airway breathing. So 30 compressions and followed by bag mask ventilation, and see if there is an advanced tube or if there, or if you have kept an advanced airway, or listen, or you can see the breath sounds you can hear. Okay, so this is a very classical question that have been asked. They have not mentioned whether it is BLS or an ACLS scenario, but looking at it, it is looking like a BLS scenario, right? So breath sounds hearing, generally we don't do it in BLS, but fine, that is the last step which I am going to do, right? So because in chest compressions, we do chest compressions and we start ventilating and see whether the chest rise is there. And one point we need to remember, I don't want to repeat all the steps of BLS again. High quality chest compressions, give adequate time for recoiling, avoid minimal interruptions, the depth should be this much. So all these things we have discussed in detail, but one take home point I wanted to stress, this is very, very important. So 3 classical questions what they have asked. You can see the pattern of asking the question. One is on ARDS or COVID or something related to ventilator. The second one is regional anesthesia. The third one is basic life support or advanced cardiac life support. Every year they are asking the questions on the repeated fashion. So please go through this algorithm very clearly. The first one is verify the scene safety. Then check for responsiveness, already I have told. So call for nearby help, get an AED, look for breathing. If the patient is not having breathing, start CPR immediately, 30 compressions and 2 breaths. And if the medical team arrives, or you have to see whether while ventilating you can see the chest lift nicely coming up and down, or if you have a stethoscope with you, you can hear the breath sounds. So this you can, by looking at the algorithm, you should be able to memorize this algorithm. It's not like just remember randomly. This algorithm is vital for a doctor, for your practice. In my day-to-day practice also, this is a very vital step. And please, those who have not learned this algorithm properly, please make sure that you write down, because this every year they are asking this question. Okay, so what is the physiology of chest compressions? What was the historical aspects? I have discussed elaborately in the chapter of CPR. We have discussed it. We have created a separate module here. So in that CPR module, you can see how we have proceeded. Suppose if there is a pulse is there, what to do, how to analyze, what are the rhythms that we can analyze in ACLS, That is sinus tachycardia, what to do, in adult tachycardia, what we have to do, adult bradycardia, what we have to do, in systole, what we have to do, ventricular fibrillation, what we have to do. So we discussed in detail about advanced cardiac life support and basic life support, which is very important for your entrance examination. Please make sure that you go through this. So I don't remember the options exactly, but this was the question they have asked. So take home point is, please make sure you remember the steps of basic life support. Okay, right? Shall we move to the next question? Right. Which of the following is not included in rapid sequence intubation? Again, this is purely anesthesia based question, right? So what is rapid sequence intubation? If you remember in my videos, I told you a scenario. A patient just had biryani. I used this word. I remember every time I use this word only. A patient just had biryani, came to casualty in a respiratory distress state. What is the problem? The problem is there is a chance of aspiration of the food material. How to prevent this aspiration? We use a maneuver. What is the name of the maneuver? The name of the maneuver is called as Selix maneuver. I used the word Selix maneuver. What do you mean by Selix maneuver? That is rapid sequence intubation or emergency intubation. There is a chance of aspiration. So what we do is we apply a cricoid pressure. Why cricoid pressure? Because I told you cricoid is a semicircular shaped cartilage. So that will be completely encircling. So what we can do is by applying the pressure, we can manually compress the esophagus and prevent the aspiration. Right? So which of the following is not included in rapid sequence intubation? Let us see the options. So pre-oxygenation with 100% oxygen. This is very vital. Even though it's an emergency, whatever the time that is available for me. What is the significance of pre-oxygenation? Because I am giving muscle relaxant for the patient. Classically, what will happen? All the muscles will be paralyzed and the patient will not be breathing. So if you put it, if I give the muscle relaxant to you right now, you will start desaturating very quickly. So what we do is we fill up your lungs with 100% oxygenation, even though it's a rapid sequence intubation, emergency intubation, whatever the time that is available. For an elective case, I will use 100% oxygen for 3 minutes. For an emergency surgery, I use 8 vital capacity breaths. Still emergency, I use 4 vital capacity breaths. That's I said. So if time is available, definitely I will not take out my leg without, or I will not use a laryngoscopy, or I will not use an intubation for a patient without using pre-oxygenation. So pre-oxygenation is mandatory for me. Whatever the time, even 3 minutes is available, that is fine, very good for me. It's an emergency. Suppose 3 minutes is not available, 8 vital capacity. If it is not available, 4 vital capacity. So whatever the small precious amount of time that is available for me, I am trying to pre-oxygenate the patient and provide some amount of oxygen reserve for the patient. So this is included in rapid sequence intubation. Pre-oxygenation is must. Okay, used in cardiac arrest patient. I said you this is an emergency intubation. So cardiac arrest is also an emergency. So definitely cardiac arrest is also an intubation for it. Fine, very good. It is used cardiac arrest or anything. You can have a aspiration chance will be there. Definitely you need to use it in rapid sequence intubation only. Fine. Induction agent and muscle relaxants are given simultaneously. This is not a appropriate answer, because I said you there is something called as if you remember in rapid sequence intubation, I said you there are two things. One is classical rapid sequence intubation and another one is modified rapid sequence intubation. I discussed this in the chapter of intubation, airway management chapter. I told you this. Classical means what we used to do is when I was postgraduate, in the beginning days of my post graduation, when a patient is coming for rapid sequence intubation, what my professor used to say is use Selix maneuver, right? That is cricoid pressure. How we are applying cricoid pressure? I told you that at the beginning of the surgery, I am keeping some amount of pressure with 10 newtons of pressure. After some time, after the patient, so what we do is we apply IV cannula, we keep the monitors, everything we keep ready. So first apply gentle cricoid pressure, give induction agent. Mostly in olden days, we used to give thiopentone sodium. Followed by succinylcholine. followed by, please try to understand, followed by succinylcholine. Never give succinylcholine first, then thiopentone, because all the muscles, this is one of the horrifying experience that a patient can experience. All the muscles, one by one, all muscles will be paralyzed. That's what I said you. So if you are aware that your arms are not moving, hands are not moving, diaphragm is, you will be feeling like this. So this is horrifying experience for the patient. So mandatorily we give thiopentone sodium or any induction agent first. Mandatorily we use thiopentone sodium first, followed by succinylcholine. It's not combined, right? So I give thiopentone sodium first, so the patient will be knocked off. Then I give succinylcholine. So after patient is knocked off, I increase the cricoid pressure. And very important in classical rapid sequence intubation is avoid bag mask ventilation. Avoid bag mask ventilation. This is what we have been taught. So later, after a few more years, because there are chances that the patient might desaturate, what we have done is, and we have got better drugs also. So we have slightly modified it. That is called as modified rapid sequence intubation. We can use gentle bag mask ventilation, keeping a pressure very low tidal volume, so that the patient gets very minimal. That's what the studies have proven. And instead of thiopentone sodium, of late we are using propofol. And if the succinylcholine is contraindicated, you can use rocuronium at a dose of 1.2 mg per kg, so that the onset of action is very similar to succinylcholine. Right? So we increase the same cricoid pressure. And remember, very important thing is remove cricoid pressure only if you put the endotracheal tube in and cuff inflated, then only remove the pressure. Otherwise there are chances of aspiration. And what is the main purpose of the cuff? I told you the cuff is used to prevent aspiration. So this is what we have discussed: classical and modified rapid sequence intubation. And every year the take home point you need to understand is, every year they are asking one question on airway management. These are the standard questions. So every year they are asking the standard pattern of questions in the NEET examination. So induction agent and muscle relaxants are never given simultaneously. First we give induction agent and then we use a muscle relaxant. The fourth option is not very clear, but might be they said high volume cuff is used, or low pressure cuff is used. Again, this is what the classical endotracheal tube is. The cuffs are divided into high pressure cuffs and low pressure. High pressure, low volume cuffs, low pressure, high volume cuffs. Of late we are using low pressure, high volume cuffs only, right? So what is the not correct option here? Induction agents and muscle relaxants are given simultaneously. Okay, so this is very important take home point for your entrance examination. If you look at the question pattern in anesthesia, the question pattern, definitely they are asking on airway management, they are asking on the BLS and ACLS, they are asking about the ARDS, then they are asking about the regional anesthesia. These four are the key areas. Let us see what is the next question they have asked. Okay, these are the 4 or 5 questions. So please try to understand, they are following the standard pattern for the entrance examination. So those students who have prepared, those students who are preparing for the NEET examination also, please make sure that you concentrate on these areas. Airway management is essential. I have shown you the various gadgets, how to do intubation, how to show some videos of intubation, insertion of LMA, etc., etc. Rapid sequence intubation is not practically possible for me to show you a video because it's an emergency intubation, right? So you have to see it in your hospital definitely. And this is a not new one. We have discussed about it. So if you apply small amount of logic, definitely you can get the answer very easily, right? So these are the classic areas what the examiner is going to ask. So by this time, your results, by the time you are listening to this video, your results are out. You might be thinking, sir, what is the point in it? The point is not getting the correct answer. What are the areas where we have to concentrate? That's the whole take home point of this revision session. And remember, those students who have not got a good rank in the INI-CET examination, this is a journey. This is a journey where we are trying to improvise ourselves. So don't get disheartened by the rank, looking at the rank, or feel bad. sir, that I have prepared well. You might have high expectations, but somehow don't get low, because there is one more examination, and this is one examination where you can get your dream branch. Might be some dream branch, so don't get depressed with the results what they have given. So gear up your preparation, start working on your preparation, and do best in your NEET examination. I wish all the best for the students, those who are coming preparing for the NEET examination. So these are the only 4 questions. Every year they ask around 4 to 5 questions. So if you have anything, just put me a message or something like that. So with this, I conclude this session and wishing you all the very best for the NEET examination. I hope you get the areas which you have to concentrate on the anesthesia, and that's the end of the session. Right? Thank you. All the best.